Thank you. It's Monday, January 27th, 2025. Thank you. I'm glad you got the comeback on that. That was good. Human Services Committee, it is called to order, and there are a couple of things on our plate. One is the DCT overview presentation. Thank you, too, for being so flexible last week when we had a pretty in-depth conversation, but I appreciate the work you've done up until even now. I mean, the work that you do is just really crucial, and I appreciate you, too, for being flexible on that. And then Senator Rasmusson, you just had a bill that was introduced today, and so we're gonna take an informational look at that, go into the weeds a little bit about get to the whys and the hows, and then have a conversation that should be pretty lengthy. Senator Utke, there's a whole list of yours on there, but I don't know. Senator Utke.
Mr. Chair, is that known as being hot off the press?
That was pretty good. We're here till Tuesday. Don't forget to tip the people who let you in this room. So, Carrie Briones and Dan Storkamp from Direct Care and Treatment are here to give us a wonderful overview about what's been going on since we passed last year, the succession of DCT from the Department of Human Services, kind of give us an update where we're at with that and what do we need to do. So the floor is yours.
Mr. Chair and members, thank you. For the record, I'm Dan Storkamp, Operations Director for Direct Care and Treatment, and with me today is Carrie.
Carrie Briones, Legislative Director for Direct Care and Treatment.
Her mics really, is there any way that they can, unless you might have to eat the mics, I don't know.
Is that helpful?
Yours is good,
Okay.
Carrie.
Carrie Briones, Legislative Director for Direct Care and Treatment.
Okay, get over here, we're good? Still seems, all right, thank you, go ahead.
Sounds good. Well, we're going to be tag teaming today and presenting kind of where DCT is at, giving you a couple updates, as well as kind of some of the challenges that are before us, and then concluding with where we are with the DCT creation projects as we kind of move forward. Mr. Chair and members, thanks for your patience this morning, the technology piece to get that up and functioning. I think we've got that set up here and ready to go. I'm going to have, actually, Marshall Smith asked us to present today on his behalf. He wasn't able to be here, but appreciates the opportunity to present DCT and kind of what we do and where we go. So with that, I'm going to have Carrie start out with kind of an overview, and we'll be tag teaming back and forth.
Chair and members, thank you for taking the time to let us provide a short overview of Direct Care and Treatment and the important work that we do. Direct Care and Treatment is a highly specialized behavioral health care system. DCT is the only behavioral health care system of its kind, scope, and size in Minnesota, so it occupies a unique place in the state's mental health continuum of care. We treat patients and clients that other healthcare providers cannot or will not serve because patients' conditions are clinically complex and their behaviors can be challenging. Some healthcare providers do not have the capacity or facilities to treat these patients. Others do not have the clinical support expertise or support staff. DCT facilities are not open to the general public. Admission is by referral only. Most referrals come in from county social service agencies, courts, community hospitals, and mental health care providers. With few exceptions, our patients and clients have been civilly committed as one or more of the following: mentally ill and dangerous, chemically dependent, developmentally disabled, as a sexually dangerous person, or as a sexually psychopathic personality. As a healthcare system, DCT is similar in size to Centracare, one of the state's larger healthcare systems. Each year, we serve about 12,000 patients and clients in our treatment facilities, residential group homes, and vocational sites. We have a statewide footprint when it comes to our facilities. As you can imagine, it takes a lot of highly trained clinicians and expertise direct care staff to deliver these services 24/7, 365. From a personnel standpoint, DCT is the largest department within the Department of Human Services. DCT has about 5,000 full and part-time staff, and approximately 85% of our budget is for staffing. DCT's annual operating budget year accounts for a very small percentage of the agency's overall budget. Fingers are sticking here. DCT has 5 major service lines: mental health and substance abuse treatment services, forensic services, community-based services, outpatient services, and the Minnesota Sex Offender Program, which is the nation's largest secure treatment program for civilly committed sex offenders. We also have 5 supporting divisions, which are Operations Support Services, Behavioral Health, Executive Medical Director, Outpatient Clinic Operations, Pharmacy Services, and our Quality and Compliance. Oh, I'm going to go back one. I'm going to hand this over to Dan for a moment.
Yeah, just as a reminder, DCT is a very unique system out there. There's not one that really is like us in anywhere. We provide hospital care for CD and mental health. We also provide inpatient treatment in secure environments. And with the 24/7 operation, that means 85% of our budget goes to salary. And that salary is for operating our program.
Dan, I'm gonna just stop you for a second. And it must be my years of drumming, but if I don't hear something coming through it's really hard for me to hear just the natural audio. Apparently the mics are working, but they're not working in my opinion. Matter of fact, this isn't even working. You gotta like either eat it or can we get somebody to, fix these microphones so I can hear you coming through. So it's hard for me to understand. I don't know, members, can you guys all hear them okay? You can? So it's just me, Glenn, is that what you're saying? Okay, thank you. All
Mr.
right.
Chair, can you hear us now?
Yeah, no, it's fine, Dan. I want to be able to hear the attainable audio, but I'm not able to, and it's hard for me to really take what's going.
It's not real clear. I mean, I can hear what they're saying, but I got to listen real close.
Okay, all right, thank you. Go ahead, Dan, just keep going.
All right. Well, we're going to talk about our top pressures today, as well as we'll talk about some updates. So I'm going to ask Carrie to give an update on our top pressures. And it sounds like we are back on the mic.
It sounds like Ms. Senator Utke, thank you for getting up and going over there, and they did it. Thank you. Nice job. Go ahead, Dan. I'm happy now.
So today we would like to share with you, with the committee, just some of our top concerns right now. Wow, it is much louder. Our number one issue right now is staffing. Recruiting and retaining staff is our top priority for the foreseeable future. As you all may be well aware, the healthcare shortage for the workforce is a critical concern. While we've hired hundreds of new staff, we still have hundreds of unfilled direct care positions. Staff are putting in a lot of overtime, and burnout is a real issue. We're placing an intense focus on recruitment and retention right now, but lack of staff can erode quality of care and lead to unsafe conditions for patients, clients, and staff. Regarding rising demand for services, DCT is under constant pressure to admit and treat more and more patients. This can be challenging based on the acuity of patients, as DCT is seeing greater numbers of patients with high aggression and volatility. Today, we have a limited treatment capacity, and the waiting list for admission to DCT facilities is substantial and continues to grow. We have taken steps with our existing facilities to expand capacity, but do not have additional buildings or space to add more. We've expanded our child and adolescent behavioral health hospital in Wilmer from 8 to 16 beds. We've reopened the Ironwood unit at the Forensic Mental Health Program in St. Peter, allowing us to maximize forensics capacity. And with the legislature's approval last session, we are currently in the process of closing the CARE program in St. Peter and repurposing the facility to add 16 more beds to the Forensic Mental Health Program. Regarding discharge difficulties, too many patients remain in our facilities long after they are ready for discharge because there are not enough step-down treatment options. The primary impediment for timely discharge is the lack of community-based programs, treatment options, and we cannot admit new patients until these patients have appropriate placements elsewhere. We would like to highlight that counties have worked collaboratively with us to improve those who are waiting at AMRTC in particular from 40% to 28%. And then an additional pressure is the priority admissions. At the legislature's instruction, we developed and implemented a new framework on July 1st of last year for addressing priority admissions. The new framework lays out several factors to consider when prioritizing people for admission from jails rather than only days waiting. Factors include medical acuity, accessibility to treatment, and impact to the referring facility. And the Priority Admissions Review Panel will soon submit a report and recommendations to the legislature on this topic.
Do you want us to ask, if people have questions along the way, do you want us to ask you, or do you want us to wait till the end? Members, what do you want?
Whenever
Ask
you
along
want.
the way? Because I was like, the report, like last year when we established the priorities, that priorities piece, there's a report, I believe, that either is due or was due, or is that going to come in front of us, do you know, this year?
Chair and members, the report is due on February 15th from the Priority Missions Review Panel. They're just finalizing it at this stage.
Okay, so then we'll add it, we'll get that in the queue, David and Bryce on that, so thank you, go ahead. No, Glenn, go ahead. Yeah.
Oh, thank you, Mr. Chair. Yeah, thanks for your presentation. I spent a lot of time on the Health and Human Services Committee when I was in the House. And when you broke this down here to the direct care and the treatment divisions, a couple questions came up. One, we had a presentation at one time where an individual was in a single house. He had to have 24/7 care, very violent, and it was costing us $1 million, if I remember right, $1 million a year to take care of him. Is that still going on, and how many situations if it is, how many situations like that do we have?
Senator Gruenhagen, thank you. Dan, you have
Sure,
there's a
Mr.
few,
Chair.
actually, Dan, there's quite a few on that. I know one WO, which is one that Senator Abler and I know well in Coon Rapids. They were part of the Olmsted, not the Olmsted, but the Jensen settlement agreement that occurred because of the mistreatment of people in Cambridge. So do you want to go ahead and answer that, Dan?
Mr. Chair, members, and Senator Gruenhagen, we've had a lot of individuals funnel through the system that need that type of care, one-to-one intensive care because of the type of activities and behaviors that they've got. WO is the individual that I think you're referring to that we've talked about. We've looked at all kinds of other options, and I think we have identified a less impactful budget-wise alternative for him in that process, but it wasn't without a lot of help and support from legislature in those pieces. We are looking at all kinds of opportunities that help address the needs that are out there, and everybody that comes to us comes with a very unique need at times.
Senator Abler to the follow-up on Senator Gruenhagen.
Sometimes you think if you just push the same topic enough times, you're going to win. That's not true on this one. And I don't know that it serves him best the way it wound up, but is he still in that house? Not that that's the only question I have. I don't ask any more information, but is he at a different venue or the same venue?
Mr. Storkamp, I believe he's referring to the one that you mentioned that you just talked about.
Mr. Chair and Senator, I'm going to have to double check. I think he's in a different placement at this time, but I'd have to verify that.
Thank you, Mr. Storkamp. Senator Abler.
Well, just a final comment. There must be archives of one or several hours of discussion about this, but just to remind you that there are people who actually are very interested in helping and all this did was disrupt the whole neighborhood, and people moved away, and they bought weapons to protect themselves for fear in a neighborhood that was probably the most embracing neighborhood in the state of an individual with those kind of challenges. So
yeah, I remember that.
And nobody listened, and we had the fire department and the police here, and anyway, so if you can, as you tutor your new people and your new independents, this is an example about how not to do one like that, with all respect to the man and all that stuff. So thank you.
Thank you, Senator Abler. I remember those discussions for years. Senator Gruenhagen, and then to Senator Mayquade.
Oh, thank you, Mr. Chair. Yeah, if we can help you in any way to work with these people in a effective but more cost-effective way too, we want to take care of things, but on the other hand, $1 million a year for one person gets to be a lot. But my other question is I get, and these are my constituents, I get a lot of concerns about mental illness patients in our jails and in our hospitals that are clogging up the system. And I know we have a law, they are supposed to be placed within a certain period of time.
The priorities, 48 hours.
What's the situation on that so I can respond to some of my constituents? And are we trying to find some type of a solution so that we can alleviate this local county and hospital bottleneck? And I know these people need help, okay? I'm not saying they don't. But it is really clogging up the system back in my county jails and my hospitals.
That's
Any thoughts?
Thank you, Senator Gruenhagen. Dan, that's the real question, what Senator Gruenhagen just brought up, and that's the task force, that whole thing, that the priorities task force. So I'm glad, I think we'll get some answers on the February 15th, but Dan, you want to update us on what Senator Gruenhagen's bringing there?
Mr. Chair, members, and Senator Gruenhagen, I would say that the Priority Admission Task Force met last year. They identified a new process that DCT should be using for admissions to help with that backflow. In the process, we came to legislature, actually was put in with a sunset that's out there, and that is something that we're going to be coming back and saying that's actually working. Let's keep it going and seeing how well it can continue to work as we kind of move forward. It doesn't solve our problem. We don't have enough beds in our program or even in the other programs. Our CEO always talks about a 12-inch ruler. And on the 12 is where DCT is with the very tail end of the individuals. And we really need 6 through 11 in order for us to be effective, both for getting people into our system and getting people out of our system. And we're missing that 6 to 11 in the community. There's pieces out there, but there's an awful lot that we have to look at as far as an incomplete system. And that's something I think that would be very helpful if we looked across the entire board and say, how can we provide those resources throughout the process so it isn't just about getting people into the tail end of the system, but how do we prevent somebody from getting there?
Yeah, it's interesting, and we're going to go to Senator May Quaid on that, but the home and community-based services, we know what's the most effective way to get people the supports and services that makes sense, right? And we know that there's been case law that says the exact same thing where we believe that is to be true. So I'm really looking forward to that report and then the what's next, right? So Senator May Quaid.
Thank you, Mr. Chair. And I just want to be mindful, I mean, whenever we talk about direct care and treatment, this is maybe, to my knowledge, the only direct health care that is provided by the state to patients. And so because of that uniqueness, you know, when we're talking about individuals, right, like that's a really private thing to be sharing in a public meeting. And so I would love for us to be really focused on the systems and the pieces that we do with the law, but not on individual people's treatment, because that just seems inappropriate.
Thank you for that reminder, why we exist as a committee, and that's exactly, yes. We'll, thank you very much, and thank you for being part of that conversation. So, Mr. Storkamp, go ahead.
Mr. Chair, Senator McQuaid, agree entirely. And as we talk about kind of direct care and treatment, we really deal and treat people that aren't or can't be treated in the communities. People don't want to treat the people that come to our program. So we have that very distilled population that we're working with, and working with DHS and others on best options as we kind of move forward. Let me give you a couple updates in a couple areas. Last year, you've asked us to actually put together an SUD report for substance abuse programs since their care. St. Peter was moving to a healthcare facility. You said, are there other programs that are out there? Our report is with DHS in review at this point. We are going to be bringing forward options, and when that comes forward, we'll be able to talk about those options as we kind of proceed. But it should be in the final steps, and it should be out shortly. Last year, we also had the legislature tell us to move our care facility to a mental health facility. And we, as of January 1, stopped taking admits to the program. And we've started some internal type of adjustments for the new population coming in. We're anticipating by March 25th that the population will be out of that program, so we can actually then make the big adjustments that we need to make to convert it over to a health care facility. And we also began working with HR on the staffing pieces. I know that was one thing that was really important to this group, is that we provided them incentives and give them options. Our goal is really to retain all those staff. We need people in DCT and have a fairly high vacancy rate right now. And then the last area is this committee was very generous to us to help us with our electronic health record as we move forward. And we had actually 3 phases of this as we proceeded. The first was really to revamp the system from admission to discharge for all our programs in the medical area. Second was looking at revenue as well as additional components being completed. And the third was really interoperability, and this was going to be a 4-year effort that we were looking at. Phase 1, admission to discharge. actually had 8 new modules, 3 enhanced modules, 37 new workflows, 129 new processes. We had 50 super users that spent a day a week for 8 months to help design this system, and 2,600 users all going live on one day. And then 2 days later, we had the CrowdStrike, where we had the blue screens in the process. But because we had our incident commands in place, we actually were able to address all those aspects. But very successful first phase. In the second phase, we're starting to look at things like revenue. Can we increase the revenue coming into the state based on billing differently and how we bill in that process? We're also looking at our central pre-admission, the entity that brings people into our program. One of the things we want to do is move them away from a spreadsheet and move them into actual electronic health records. We're really wanting to get out of paper in this whole process, and I think we've got a huge way. One of the key things for our success was really incorporating a lot with our users, making sure that they knew what was coming up. They had training for 3 months prior to. Those who are using the program the most got the most training. And when we went live, we actually had people on site. We had a 24/7 line they could call for 30 days, and we were able to then follow up, and we're actually now doing an evaluation of what our users actually thought of it pre and post, and we'll be looking at that in about 30 days, or 33 months or thereabout at this time. So we're very excited about that. And then the big piece that I think this group is very interested in is the DCT as a separate entity. One of the big things that we had to put in place by statute was an executive board by January 1. We were able to get that in place. They've actually already met. Just as a reminder, there are 6 members appointed by the governor. The commissioners of DHS sits on that board. Then we've got 2 non-voting members, one from the counties and one from the unions that represent DCT. We've got all those in place. Their first meeting was really about how they're going to operate and function. We've got 5 additional meetings already set up before July 1, so they understand not only what DCT is, where we're at and what we're doing, but also in terms of knowing what a board does. We're actually having the Minnesota Hospital Association come in and talk about boards and how hospital boards work in the direction that they go and support the healthcare program. We've got 3 members that are either doctors or nurses, and that was one of the key pieces, was bringing in that healthcare experience to understand what the healthcare system does as we kind of move forward. And very excited about kind of the next phase of that process as we kind of move forward. Next slide is really looking at more of the operation side of things. When we were here last year, we said that we wanted by July 1 of last year to have in place all the work groups, 47 different work groups, action plans. So we knew what they needed to get done for us to become our own agency July 1. We actually achieved that goal mid-May, so a couple of months earlier. And if you go to the next slide, July 1 of this past year, we were transitioning to July 1 of next year. We need to have 100% complete in order for us in all these 47 work groups to support DCT as a separate entity. One of the key things here is the darker the green or the black, the further it is along. So I'd like to then switch to the next slide, which says as of today, we have significant progress made in many of the areas, so we are ready to move forward. I've got 2 project managers that coordinate these 47 work groups, and they're indicating that all 47 are going to meet that July 1 deadline as we move forward. So with that, those are quick updates on kind of where DCT is at. Questions?
Members, any questions about what we started last year? Senator Rasmusson, then Senator Etke.
Thank you, Mr. Chair. And Mr. Chair, this question may be for you. Do you know, are we going to have DCT come back at a point in the future to make a budget presentation? Or is this, going to be the only time they're in front of the committee?
No, they're to that point, Mr. Chair. It is my understanding that we're eventually going to get the budget presented to us from, or the lack thereof budget, right? But that'll be a separate piece, and I don't know when that will take place. Dan, do you have an idea when you will be ready for that?
Mr. Chair and members, I think we're waiting for the committee to decide when you would like us to come up and present to you, along with DHS as well as the other governor recommendations.
Thank you. Senator Utke.
Thank you, Mr. Chair. Question, I heard a couple different comments, and just maybe for a little clarity, because some of us had a chance to visit one of the facilities that was in St. Peter this summer. And you talked about transitioning the care program in St. Peter and some of these step downs, et cetera, but then talk about not having enough rooms. Is that across the programs? I mean, you got numbers of locations, but I know when we visited St. Peter, there appeared to be extra rooms, or there could easily be extra rooms if you had a place to move people that have been there a long, long time and actually needed to go to a step-down facility. Is it the fact that you don't have those step-down locations? Or, I mean, it seems like we're maybe not using the facilities as efficiently as they could be just because there's no place to move certain people that actually deserve to be in a lesser confined area.
Thank you for reminding us, Senator Utke. That clearly was something that jumped out as like, and then as the report is, where's the capacity, or we don't have any home and community-based services. So thank you for bringing that up. Dan, Carrie, what are your thoughts?
Mr. Chair, Senator Utke, and members, that is exactly what we're looking at today. Is we have individuals that if we could get out of the system, we could bring more of those waiting lists into the system. That was one of the efforts with moving the care facility to a mental health facility, is now we're going to get 16 more beds that we can move people out of so we can get more into the facilities in the process.
Interesting. I'm glad you brought that up. Senator Utke.
Thank you, Mr. Chair. I guess my question back then would be, is that something you will bring more information, basically a request, and, to let us know, we need so many more beds, or what is the data that comes with that, rather than just talking about needing more beds? Bring something that's tangible. This is what we need to move the program forward and be more efficient, et cetera, however it plays out.
Almost sounds like we need Dan to put on his operations hat and give us a facilities. Like, is that what you're asking for?
That's right.
God, he could probably do that right now. Does that make sense? You want to come back, Dan? And I mean, that's because we're talking about capacity, we're talking about beds, and even last year when all of a sudden, it was recognized Carlton would be shut down. I'll never forget going through the list. Senator Utke said, let's see, homeless, pregnant, he started listing all the things. He goes, yeah, that's a checklist you don't find every day. These are the most vulnerable people. And then that caused us then to get into the conversation about, well, what is the capacity thing out there? So maybe we should have you come back next week and, do you have that ready to go?
Mr. Chair, members, that is, I think, the million-dollar question, because this isn't about just DCT. This is really about our mental health system. And what we don't have aren't necessarily the DCT beds. It's really being able to bring them back into the communities and address them at a lower level in that process. We can talk about adding more beds to DCT, but we can't build our way out of this situation.
It's interesting. In Senator Utke, I remember Senator Senjum years ago, I thought he had set some money aside for like a transitional, seamless, get people back to the community, but set up some regional hub money. And unless I maybe had a dream about that, I remember that was something that was bonded for. Does that ring a bell to you?
Right. If I remember right, I think he bonded about $25 million to be divided up into at least 5 different hubs, but the different areas would have proposals and stuff. And I believe all that money did go out to create these hub facilities, so to speak, but I don't know that that's always exactly what we need either, because these people coming out of total, basically, confinement, they don't go into a day service or someplace that you walk in and out of the door. They need to transition at a rate where they can succeed and yet get the care they need until they're finally through the system. And so I think this is a little different than what was proposed back in those days.
That's always that systemic question out there, right? And yet you know, we know there's still 53,000 job openings in the caregiver bucket, which some of those are the community-based places. So this is a good conversation. Anybody else got anything to add to that? Senator Rasmusson.
Thank you, Mr. Chair, and appreciate the presentation and conversation. And maybe this will be for your budget presentation. Is there any plan to ever be in compliance with the 48-hour rule?
Is that a fair question? Dan, what are your thoughts?
Mr. Chair, members, Senator Rasmusson, I would say that there's a challenge there for all of us, that I think our waiting list is somewhere about 300 individuals coming into the program. And if you want to build your way out of it, we could build and build and build in order to do that. We also have got the discharge that Gary talked about, that we've got people that do not meet hospital level of care that we can't get out of our facilities. If we were able to get some of them out, we could get more people in the process. So I really think that this is really more of a holistic view that we're gonna have to talk about how do we get there in order to do that.
Thank you, Mr. Chair, and thank you. And the reason I bring it up is, I had a constituent this last year who was in the Otter Tail County Jail for over 100 days, waiting for one of these facilities to open up. And I guess and we can talk more about this when the budget conversation comes up, but just to preview that a little bit is, we continue to see more rural 20s. We continue to see more mentally ill and dangerous designations. We continue to see the demand metrics go up, but I don't see a corresponding increase in terms of the capacity from direct care and treatment. And I think that's one of the, when I talk to counties, when I talk to hospitals, when I talk to law enforcement, that's one of their biggest concerns, is we're seeing more cases on the ground, but we're not really resulting in materially different, options for those individuals. And so then, that's how the 48-hour rule turns into the 100-day rule. And I think that's something that we have to put attention and focus on in this committee when we're looking at budgets to see how we can better address that. Thank you, Mr. Chair.
No, I think you're on. That was that whole question. I remember years ago, Senator Abler and I, when we were touring in Anoka, and it was, I think the folks said it was well over 2 years that they received any kind of referrals from hospitals. Do you remember that? I mean, it seems we've been having this conversation since he was chair, even prior to that, right? I think we as a committee, this is what we should be tackling. I mean, is there, what are your thoughts on that? I mean, Senator Mayquade, Senator Radke, Senator Abler, you were all there, right? I mean, what are we doing in that aspect? Because maybe we wait till February 15th when the report comes up and we can start asking. I would assume Matt Freeman and his team will be sitting at the table. There's a report that we're going to have, yeah. What do you think, Jim?
Mr. Chair, we could read the report.
That would be good.
Thank you.
February 15th. Oh, my God, forget it. That was good. We'll wait for the 15th. Carrie, Ms. Briones.
Chair and members, I was going to add along that point that last year there was quite a bit of legislation that was passed that came out of the initial report out of the Priority Interest Task Force. And so we haven't had quite a year for all those different pieces to go in place. And part of the work that the Priority Missions Review Panel is doing is monitoring that. But also that report will come with recommendations to address the entire spectrum. The members, as you may be well aware, were from across the behavioral health care system. So it wasn't just DCT's view or the sheriff's view or the counties. All these folks came together to really have a collaborative approach to the system and to address the issues. So I know they're making several recommendations in the report for you.
And that will be on the 15th, correct?
I sure hope so,
I
Chair
love
members.
it. Senator Rasmusson, yeah.
Thank you, Mr. Chair. Just one final question for me. For the testifiers, do you know how much this transition effort has cost the taxpayers to stand up a standalone direct care and treatment agency?
Mr. Storkamp?
Mr. Chair, Senator Rasmusson, we don't have that today, but it's something we could look at doing. And I think you'd be looking at all the resources that went into making this conversion, correct?
Senator Rasmusson.
Thank you, Mr. Chair, and a follow-up for Mr. Storkamp. Mr. Storkamp, do you have any estimate, or as this was being contemplated, was there any estimate for the cost that this would, mean for the taxpayers to stand up this as an independent agency?
Mr. Chair and Senator Rasmussen, members, the direct care and treatment was minimal cost because we've been separated with inside DHS to begin with for the most part. 98% of our staff are already reporting to DCT, so the transition for them is very easy in that process. They don't move, they get the same employee, they get our same boss, same workload in the process. We've actually worked with DHS on the other 2%, and I think we're down to 6 people who are going to change supervisors out of all of this time. So there isn't a lot on that time. It is really looking at how do we support an organization like this and transition things that DHS was doing, that we were paying them for, that we now do with our own staff.
Thank you, Mr. Storkamp. Senator Rasmussen, you want to get, at least Bailey, maybe she knows top of her head. Does she? Do you know how much? Don't come down if you don't have to, but do you know how, was there? Yeah.
It was very, very little.
Yeah. To Dan, I think that part, and I remember seeing that, Senator Rutke. Do you remember seeing those numbers? They were not that. All right.
Yeah.
That sounds good. All right. Maybe we'll get those, you can get that prepared for us and send it to the whole committee. Thank you. Any other final thoughts? Dan or Carrie?
Thank you for the time, and we look forward to the discussion about the options and beds as we kind of move forward and our budget as we move
Sounds
forward.
like you guys will be hanging out there as Senator Rasmussen comes over there. We're going to talk about direct care and treatment establishment conversation from last year. So thank you, too. Members, just to, as Senator Rasmussen's going, Senate File 626 was actually dropped today because it was, there's a rule regarding bills that are introduced and getting a hearing in a committee. So this is not an actual hearing. There's no formal action. This is for discussion only. Even the A1 amendment that he'll bring back next week is for discussion only. But this is what we had started having a conversation last year, members. If you remember, there was kind of this committee was split on, do we go this direction or that direction? I believe that conversation under my suggestion to Senator Rasmussen was, well, we have until July of next year to fix this. Let's get to work on that then. And so am I regarding correctly on that, Senator Rasmussen? This has just been an ongoing conversation, again, facilitated here. We want to do the right thing because, we want to focus on the unique needs of the individuals we should be serving in the matter at hand. So with that, folks, we're just going to be having a discussion. Dan Storkamp, you here. We got Michelle Aldine. Is she related to the country artist? And then there's in your packet, there's a couple of letters. There's a NAMI letter, and then I guess Matt Freeman doesn't want to get in front of us and talk anymore, so he submits letters instead. So, you will come up, Matt. And so I'm kidding. Senator Rasmussen, to that, Senate File 626.
Thank you, Mr. Chair. I appreciate the conversation to discuss this bill today, and also just wanted to note that the A1 amendments posted as well for the public and folks to take a look at this language to be formally considered at a future date. As members may recall, last biennium legislation was passed to set up direct care and treatment as a standalone agency. This is an idea that's been talked about for a long time. Republicans, Democrats, many people have had different proposals to split up functions that are currently within the Department of Human Services. I'd say one unique item in this legislation that was setting up direct care and treatment as a new standalone agency was the governance model. Instead of having a commissioner serving at the pleasure of the executive branch, the governor's proposal created an executive board that would select the direct care and treatment CEO. The governor would not be able to remove that official and would also not be involved in selecting that official. The bill before the committee would change direct care and treatment's governance model back to a traditional commissioner model. There's a few reasons why I think this change in governance is very important. Direct Care and Treatment has about 5,000 employees. They have more than $1 billion biennial budget, and they serve more than 12,000 patients a year. This is a large agency that does complex and sensitive work. The board is set up to be very part-time. State statute only requires them to meet 4 times a year, and I believe it doesn't provide sufficient management oversight to an agency of this scale. In Minnesota government, there sometimes are boards that are used to run small occupational licensing boards. Those who serve on the state and local government committee have maybe heard of some of those, the Board of Cosmetology and others. But a board structure for this type of agency is simply unheard of in Minnesota or when you look to other states for this kind of work. I also want to talk about the fact that Direct Care and Treatment does highly sensitive work that is important to the safety of Minnesotans. Nearly all of DCT's patients and clients have been civilly committed by a court, including court designations as mentally ill and dangerous and sexually dangerous. DCT runs the nation's largest treatment program for civilly committed sex offenders. And if we do not pass legislation and change the governance model, come July 1, a part-time board that I don't think any member on this committee could name a person who serves on that board would now be responsible for those key decisions. I also think it's important to note that if the Direct Care and Treatment CEO took an action that undermined the confidence of Minnesotans, the governor would not have a direct path to dismiss or replace this official. The CEO, as it is in current law, serves at the pleasure of the executive board. I also think it's important to underscore that Direct Care and Treatment has some real issues to work through. We've just got done talking a little bit about the 48-hour rule. We've had discussions before, and I'm sure we will again, on the Minnesota Sex Offender Program. We had the issue last year with planned facility closures. And so to not have public accountability for this agency, I believe will reduce its responsiveness to the needs of Minnesotans. In our system of democratic government, elected officials who answer to the voters make the tough calls. And I worry that if we keep Direct Care and Treatment reporting to this very part-time board that's not accountable to the people of Minnesota, that will be making life and death decisions on behalf of Minnesotans, that this agency that we already have some challenges with will become even less responsive to the people of Minnesota. And there's a reason when we look at other major state agencies of government, whether that's the Minnesota Department of Education, the Department of Revenue, the Department of Commerce, we don't have a part-time board run those agencies because we want to make sure that there is accountability. With that, Mr. Chair, I'd be happy to move to my testifiers, and after that, I'm happy to take questions.
So thank you. Senator Jordan, I know you and I remember last year, you and Senator Omar Fata were having this conversation about what makes sense. And then, and when you look at, the makeup of the board, I know the desire was to create a hospital because it's a hospital, but yet at the same time, it's like there was still that imbalance piece that you guys were talking about. And do you want to go through, I know we can't ask staff to go through it because it's not officially a bill, but maybe perhaps if you would want to go through the article sections, or do you want to wait on that? I guess members, what do you have? For Senator Utke, talk to me.
Thank you, Mr. Chair. I thought, the bill is early. We talked about the fact it was just dropped today or just acknowledged today, but can't staff still participate? It's just at the end of the day, we can't take a vote on it until it's spent its time that's required. But I think we can have a full discussion, which would include their expertise.
And I believe Liam, he shook his head yes. So thank you for bringing that up. So,
Mr. Chair.
Mr. Senator Rasmusson.
Well, the bill is lengthy. It is quite simple. And Mr. Monahan can jump in and correct me if I miss anything. What it does in current law, come July 1, an executive board will run Direct Care and Treatment, can fire and hire a CEO to run Direct Care and Treatment. That is the status quo. What Senate File 626 would do with the A1 amendment would simply remove the executive board and replace it with a commissioner of Direct Care and Treatment that is in line with what we typically see at other state agencies.
All right.
So the reason the bill is lengthy is that there are many places that the executive board has to be replaced with a commissioner. But,
All right.
but Mr. Monahan can fill in anything that I've missed with that
I think,
explanation.
is there anything to add to that, Mr. Monahan, or did he pretty?
Mr. Chair, members, I mean, that is in a nutshell.
Okay.
I could be more specific, but I'm not certain it'd be helpful.
The good Senator Hudke, is that good? I think we're good on that. So with that, then, Senator Rasmussen, if there is no other questions for you, let's go to folks at Think. Dan, you want to go first, or you want to go to Eldine, Senator Rasmussen? Who do you want? I got Dan Storkamp first on here, so Dan, go ahead.
Mr. Chair, members, Senator Rasmussen, appreciate the discussion about kind of what organization or how to govern a body such as DCT. I mentioned in my earlier testimony that DCT is unique. We have a healthcare organization that's operating in a government setting, and there isn't a lot of those out there, especially with the different types and areas that we've got. What we brought forward last year was coming to an executive board, which really provided three things: consistency of healthcare leadership. So we've got a consistency over time. Our members are staggered so that they're coming on at different times. They don't just all go off one day and then have a brand new board come in. It provides the clinical judgment for the direction that we're going, and really brings in that doctor and nurse expertise for DCT as we proceed, as well as it provides transparency. Public accountability, the public's actually available to participate and be a part of board meetings, and all board meetings are really open and are available for documentations that are done in that process. But like I said, there's a lot of different options for governance of a very unique organization like ours, but that was the reason that we brought forward the board this past year.
Senator Fata just said, the advisory board, why couldn't that be? Senator Fata, what was your statement?
Yeah, Senator Rasmussen and Commissioner, thank you, Mr. Chair. I was thinking about why not just have an advisory board instead of an executive board that still consults with a commissioner? Senator Rasmussen.
Senator Rasmussen.
Thank you, Mr. Chair. Thank you, Senator Fonte. I think, yes, and a commissioner could set up an advisory board at will. I think that's also something, if we wanted to make sure that that's included in the legislation, we could have an advisory board. I think as a part of the transition, there's a temporary advisory board that will expire once the transition is complete. So we could also look at extending that advisory board if we felt that that was important in state statute. But yeah, there's nothing that would prevent a commissioner from creating an advisory board to get feedback from stakeholders and other professionals.
Senator Fata.
Yeah, thank you, Senator Rasmussen, and thank you, Mr. Chair. I think it would be helpful. Can you run us through like a situation, one with an executive board structure, one with a commissioner structure? Say there is a major, I can't think of an example. Say there's a major decision failure. What would be the remedy for that? What would be the process for that in both scenarios? Does that make sense what I'm asking, Senator Rasmussen?
Does that make sense? Yeah.
Mr. Chair, Senator Fonte, yes, and thank you for the question. I think that's what it boils down to, is what would you see as the differences here? And I'll give a couple of different examples, and I think we might also hear later from Otter Tail County Attorney Michelle Dean, who might talk about her perspective engaging with direct care and treatment. The first would be an example that I experienced in the area I represent, where we had an individual who was in a jail cell for more than 100 days, simply waiting to get into direct care and treatment. And so that became a news article that the Star Tribune wrote about. And again, you have a governor, whether it's our current governor or a future governor, who ultimately is responsible for that agency. The commissioner serves at his or her pleasure, and they can act, they can take action. And so for me as a legislator, I can call the governor's office, reporters can call the governor's office, and we can apply that political pressure to take action in a situation. Versus a board that has these staggered terms, that doesn't really have any public accountability, they're more insulated from that pressure, right? They're more insulated from legislative engagement, public engagement. And I think if you were to go to the governor or the governor's office in that instance and say, what's going on? Why is this happening? The governor can shrug his or her shoulders and point to this non-elected independent board and say, well, that's their problem. And so I worry that this reduces public accountability. There's a reason we don't run big agencies this way. And I think the other thing that I'm also very, very passionate about, because it deals with public safety of Minnesotans in such a core way, is the Minnesota Sex Offender Program, where you have a program and that it is tasked with having a treatment program for individuals who have been deemed sexually dangerous by a court, that have had the Department of Corrections refer them to this program. And I think it's very important that you have someone who has public accountability to voters be ultimately in charge of the actions of that agency. If you were to, for example, have individuals who are recommended for release from that program, that perhaps would go against the public interest, because there's as some people might say, there's might be too many people in a certain program or not. I think ultimately someone with an election certificate who is responsible to voters should be able to be accountable for those decisions, versus a board that is kind of nameless and faceless. Thank you, Mr. Chair.
That makes sense. Yeah, we're going to Senator McQuaid. Did that make sense to you? Senator McQuaid.
Thank you, Mr. Chair. And Senator Rasmusson, I think I've approached this with an open mind. We've been having this conversation for a year, and I think I've really internalized it. But I will say everything I've heard today makes me the most concerned about your proposal. And it's because you've talked about making life and death decisions on behalf of Minnesotans, applying political pressure to an appointed commissioner, but we're talking about the health care of individual people. And I would never want the health care of individual people to be politically pressured to a commissioner. And so I think about the example that you just gave, where there's somebody who's in a jail, right, and they can't get a bed and it's been 100 days. And in your example, you could call the governor if there was a commissioner, and you could make pressure to have that person transferred. What if there's 99 other people that actually have more acute needs in front of that person, but because there was an article in the Star Tribune, now they've jumped the line and there's 99 other counties that have another person there? So I think I'm more concerned by the idea of going to this political pressure system, because we're providing direct care to patients, and I don't want that to be politically influenced, and I don't want an article or outrage about somebody being recommended for release to influence their ability to be released when their treatment's been completed. And so that is my concern with this. I do understand that this is different, right? This is the only part of the government where we provide literal care to individual people. And so I do think that the instinct to set up a different kind of structure to honor that makes sense. And so I maybe they can meet more than 4 times a year. You said we don't have a part-time board making these decisions, but we do have a part-time legislature, right? So we are okay with part-time stuff sometimes. But I wonder if we could bolster the advisory, the voting board, instead of getting rid of it and putting it where there's more political pressure that are applied to individual people and their care, because that's not how I want individual people's care to be managed by the state.
This is so good to have this conversation, because now you got what we started. And so how would that look, I guess? Thank you for, different perspectives. And Senator Rasmusson, what are you hearing? And I don't want to, this is actually, I'm liking this conversation, so go ahead.
Thank you, Mr. Chair, and thank you, Senator McQuaid. And the goal is not to politicize decisions made at direct care and treatment. The goal is to make sure there's accountability. And I'll give an example of a bill that I worked on with Senator Seeberger last session that passed unanimously, where if you'd have gone last year, we had a emergency medical services regulatory board that was a very part-time board, met to regulate emergency medical service here in the state of Minnesota, that frankly wasn't doing their job. I couldn't name a single member. Other people, didn't know who was on this board. They weren't accountable to the public. And so as a part of that legislation, we eliminated this board and we created a directorship that reports to the governor. And again, it's not about politicizing what's happening in EMS. It's making sure there's accountability. That someone who has to go answer to the voters has to answer for these very important government decisions that are being made at an agency that has 5,000 employees, 12,000 patients a year, and more than $1 billion budget. And when you look at corollaries in Minnesota government, across the nation. There's nothing like this, where you'd have a part-time board that's only required to meet 4 times a year, that gets a little stipend, making this level of decisions. And so I think that's something that I'm concerned about. And again, it's not about politicizing any decisions, it's making sure that there's accountability. And one of the concerns that I have is the only time I've kind of seen people shy away from taking responsibility and taking that authority is when they're concerned about the accountability. And they want to be able to point to and say, oh, well, that's this, this executive board that's arm's length from government that's making these tough decisions. You can't blame me. And this isn't about the current governor. It's about any future governor that's going to have to make tough decisions at direct care and treatment. This committee is going to have to make tough decisions about direct care and treatment. And I just want to make sure there's public accountability.
Interesting.
And Mr. Chair,
I like it almost feels like there's that, more bureaucracy, less bureaucracy kind of conversation. But go ahead, Senator McQuaid.
Thank you, Mr. Chair. And Senator Rasmusson, I do hear what you're saying. And what I keep hearing is accountability for the healthcare decisions that are being made for other patients. And that is where I feel like the politicization comes in, because we're talking about a particularly heated group of people, right? These are folks, I think in the beginning of the presentation, that other providers won't or can't treat, right? And so they are now patients of the state for really specific reasons that are not comfortable for a lot of people to talk about, to learn about. I'm sure that even providers who provide certain types of healthcare are uncomfortable providing healthcare to these populations. And so when we're talking about accountability, what I'm hearing is, when the state who provides direct care to these patients makes a decision that the public might not agree with, because that's somebody else's health care, like that's where I'm getting really worried, because that's where politics comes in, or it's like you could pull out parts of my own health care and it would be really salacious across the front page of a newspaper, but it was for me, for my provider. In this case, we are the provider for patients, and I feel like this is just creating lots of opportunities to hold somebody accountable for healthcare decisions the public doesn't like, but that were appropriate for a patient. Does that make sense what I'm saying?
Yeah, Senator Rasmussen. To have the conversation, because this is, it does make sense.
Thank you, Mr. Chair. Thank you, Senator McQuaid. And one thing I want to make sure that Ms. Eldine has a chance to testify as well, because I think she can talk about some specific cases regarding direct care and treatment. But I want to just also mention,
Senator Rasmussen, I'm just thinking,
Yes.
Senator Abel, do we want to should we get the testimony up? This is a great conversation, gentlemen. Jim and Paul, are you okay if we go to after Rasmussen's done, have
and
him
I'm
go
happy to
Aldine?
take as many questions as people want.
Yeah, then, okay.
Yep, that's
You're
fine,
good?
because if it comes back, that's, however we get it, it works.
Yeah.
So let's hear from.
Senator Rasmussen, do you want to finish up, or you want to go right to your testimony? All right, we got time. You want to introduce her? We have Michelle Eldine, Otter Tail County Attorney, on board. And Michelle, can you hear us, Miss Eldine?
I sure can.
All right.
Can you hear me?
I can. It's all yours.
All right, thank you. I apologize. I wish I could be there in person. That things move fast with you guys, and here I am. But I've been asked to talk specific to DCT and the bill as proposed, which I just got my hands on here a few days ago. I'll try to be as brief as I can, but I think a little background might be helpful for those of you, because I don't think many of you have met me. I've been the Otter Tail County Attorney since 2018, but I've been with this office since 1998. I worked as a blind prosecutor, an assistant, and also as a chief deputy back in the early days. And I had the pleasure also to not only practice criminal law, civil commitment law here, but the commitments also concerning SDP, SBP patients as well, or defendants that were committed in that realm. I did work in the day when our Fergus Falls RTC obviously was operating as well. In fact, conducted hearings there. We brought the patients down to a particular room, and we went there to meet their needs. And so I have that experience with the specific RTC that was here in Fergus Falls. And then, of course, I was here during the time of the closures of the regional treatment centers in 2005-ish, specifically our facility, and how that impacted our communities, specifically the defendants that I've worked with as being in this office, and also the commitment issues that we see with public safety on the streets now, where there are no beds, and that the issue seriously that you're talking about. That's kind of wrapping into the capacity issues that myself and also MCAA, which is the Minnesota County Attorneys Association, we've worked closely, and we've had representatives from that group that have worked lots of hours trying to help resolve that issue of the 48-hour rule and the lack of beds for individuals that we're talking about here today. So today I am talking specifically as the Ottertail County Attorney, but I am also just mentioning MCA because I did speak to our board, although the bill hasn't been addressed by our board formally because of the timing. We are certainly been working with Senator Rasmusson in the past and also other specific to presentations regarding the task force recommendations and that, so I'll be talking a little bit about that. But obviously, on behalf of myself as the Ottertail County Attorney and MCA, I will say that some of the changes, of course, with the lack of beds has significantly impacted our work. It's impacted the clients and the people we serve. Between the jails, I'm going to give 3 different examples here as I get to that to kind of just give you a sense of how it impacts all things that we deal with here regarding defendants that are found not competent under a Rule 20 type phase, those that are found to meet the McNaughton standard under 2002, and then also those that are at the MSOP facility as sexually dangerous predators or the sexual predator personalities. And then, of course, the jail issues we're having because of the lack of beds and individuals waiting, as Senator Rasmusson mentioned, those that sit in our jails because there is nowhere else for them to go, even though they've been found incompetent and also have been committed, and they wait and up with issues here that we've had many of this year if you've been watching the press. And so as I kind of talk about these things, I just want to make sure that you as a group are aware that MCA and the county attorneys are working hard to make sure that the 48-hour rule now that's been addressed here with the recommendations of that task force actually maybe get attention and demands out of this association. So I know with Senator Rasmusson's bill here regarding DCT, we have grave concern that anything that would allow less accountability, which it appears obviously a board versus a commissioner moves in that direction, would cause us concern that things would only exacerbate with the issue of not having beds and not having anyone accountable to that. I heard some of the concerns by one of the senators here shortly there, but I think what we're looking for as county attorneys and also the MCA Association is clear lines of access to communicate with individuals with that department, and transparency and accountability. And we've tried for those things over the past 2 years while we've worked with the 48-hour rule, and we're kind of falling flat with some of the things that we've worked on there. So we do have concerns with that for those reasons. So as I kind of get into a couple examples, we certainly are looking for you as legislators now to obviously do whatever you can to put this as a priority. We have not seen that even after the task force report came out last year in 2024, February. And so we're begging you to take a look at that, make sure that it's a priority for not only the increased capacity, but funding to make sure that we get the extra beds for these individuals that we're dealing with to go to. So when I talked to Senator Rasmusson, I mean, I think over the last few years, we've talked about some serious situations, and I'll call it a crisis. I think our mental health situation is a crisis. I don't know that anybody could call it much less. Not only are we having the issue with less beds since the facilities like the Fergus Falls Regional Treatment Center closed, but we have the increase of individuals that appear to be meeting mental health diagnoses and issues. And as I heard a few of you mention, I think it's crucial to also understand how the increase in Rule 20 evaluations and those being found incompetent has increased this issue as well. So we're not able to really house them in jails. We're not able to put them in prison if they're not restored to competency, but they're also on a list that's ever growing because of doctors and psychiatrists and that finding individuals to meet this incompetency issue under Rule 20 more and more. And that's an issue for a whole nother day, but that is one of the significant impacts that I have seen in the past 10 to 20 years, where a Rule 20 was almost unheard of when I started, and now we see them on a daily basis. So if you kind of get the two things kind of converging together are causing, as I'll call it, this crisis of mental health in our jails and with our defendants. So just 3 examples, if I can give you, before maybe you have any questions. One of them is the first thing is somebody that is found to be meeting a McNaughton standard. In other words, we go through a trial. I had one individual in 2017 that was found guilty of murder in the second degree. He was then found to meet the 2002 standard based on, we had contested hearings related to that, disagreement of psychiatrists. However, ultimately the decision was that he met 2002. He was found to meet that standard and was placed at St. Peter on an MIND commitment. That individual, within a few years of being placed there after murdering his father in his bed sleeping, was petitioning and asking to be discharged within a few years. We have been fighting that battle with him almost within every year, if not 6 months, where he can petition. We're losing that battle now already. And if you know, 2017 to now is not a very long period of time for murdering your father in his bedroom. And so at this stage, he is looking at discharge. He is already walking the streets. I think most people in St. Peter would be surprised to know that he's frequenting Target or other places without any supervision. That's happened in this past year. Before that, there was already some moving around with ankle bracelets and things like that. But the fact is, these individuals are not staying in the facility longer. And to some of us that have worked with the system and have had to attend the SRB and the CAP hearings and bring our information about our case managers who are very concerned about this individual getting released to the community, whether it's ours or yours or someone else's, we don't believe in any way, shape, or form that individual is ready from a public safety standpoint to be in our community. However, the facility individuals, including medical directors and doctors, will make those recommendations. And right now, we've lost that battle essentially because there is nobody supporting the position that he remain and he will likely be out. And so that is one of the situations where we're seeing that happening more and more. And I don't think the public would understand as well, and maybe you don't as well, that these individuals are not staying in these facilities as long as they used to, and they are coming out. Yes, I agree with some of the statements that were made earlier that we need to be careful about the medical needs of individuals, but the reality is it feels a little bit more like an assembly line of moving individuals quickly out because there's so many people waiting on a wait list to get that bed. And I will say that is the feeling of myself and many county attorneys and individuals working with this work. That's how it feels when you read the documentation of the reports and actually see what's happening with the recommendations for release. The second example is one specific to an individual that we had here in Ottertail County that in 2020 was placed. He's Rule 2001, in other words, not competent to proceed with his criminal case. That individual I prosecuted back in 2009 for kidnapping and a sexual assault where he was sent to prison. As soon as he was released from his supervised release term, he immediately went out and did the same act. He kidnapped a woman that he knew nothing about. He basically followed her at a Walmart facility, watched her go home, followed her home, and eventually broke into her home with her child in bed with her for a nap, kidnapped and sexually assaulted her. That, unfortunately, we tried very hard to process that case through the criminal system as long as we could, which there is a limit of 3 years or so before, unless it is a murder case where that individual then would either be let go and nothing happened, or we try to commit them. In this case, because of his history and history that he had in the state of Arizona, we were able to get the Attorney General to work close with me and get him committed as a sexually dangerous predator prior to his release then in that criminal case where it was determined he would never be brought back to competency. And so he is still sitting at our MSOP program. However, the concerns there, Senators, I think is grave that, again, I feel from my service here the last 25 plus years, somebody that went to that facility would likely not get out. Now we're getting many petitions also at that level, not just the MIND petitions, but petitions exasperating the work we're doing and needing assistance from the AG and others to review those cases and to make pleas that they are not released because they're petitioning earlier and earlier to get out of that facility. So that's another example where we've seen the changes since the bed issue has become a reality. And then the other one that is really forefront right now, we've had some serious issues in our jail, not just because there's lawsuits and such, but those lawsuits and the issues in our jail are more and more prevalent because of the issues we're seeing with defendants that are sitting in the jail that should not be in the jail, but there is simply nowhere else for them to be. Law enforcement, we've been working with at MCA as well, with the Sheriff's Association and the Police Officers Association groups, because what they're dealing with is people that might have 7 crimes that have been let out with release conditions because, you know, they're not necessarily the murderers, but they are public dangers. We're seeing lower bail amounts. We're seeing them released to the streets and commit new crime after new crime after new crime. And law enforcement are dealing with them on a repeated basis. But there is, you know, the space in the jail then becomes their home, and it's not where they should be. So the reality for them is, we're sitting there, and as Senator Rasmusson, Chair Rasmusson, had mentioned, one particular individual I know made a Kara Levin story and media release. He's just one of many we've seen where the defendants are sitting in the jail waiting for that bed, even though they've been found to be incompetent, be civilly committed by our civil commitment team, and then there is no bed waiting for them. So as I bring the examples up, and we've been asked to speak specific to DCT, I guess, and whether there's a board versus the commissioner, I bring it up only in context with all of this, the other issues that we're trying to address with the 48-hour rule, because even though we've seen the recommendations come down from that task force on priority admissions, we really have not seen the legislator or DHS put priority to it. The governor's budget, I think, is one that we've just been watching. Again, there's no priorities. There's nothing in there that would show us that this is getting the attention it needs and the urgency it needs for beds to be increased. I know when we were involved with it, the legislation last year with the DHS, we were clear that we would not be in favor of any bill unless there was an increase in beds. And I think at that time we were asking for 250. We haven't seen anything like that with a nudge to see that we're actually going to have more beds to put individuals in. So this crisis of moving people kind of through the pipeline, move them out quicker so the next ones come in that are on the wait list, just cannot be the solution. And so the whole point here today, I think, of talking about a board that maybe meets 4 times a year, whether there's different things that can be done with that or not, I don't think changes the fact that anything right now with less accountability and less ability to have open communication and a commissioner that has complete responsibility. And I agree with Senator Rasmusson 100% that this is a huge area. Direct care and treatment, if it isn't priority, should be the ultimate priority right now. Our mental health crisis is only getting worse, not better. So if this is one of the, probably the most important agencies right now that we're working on, to have it with a board that is responsible versus a commissioner just doesn't seem to make sense right now with the timing of everything we're seeing here. And so I would ask that you give priority to this whole issue with direct care and treatment, the lack of beds, worked on as much as possible, the increase of that capacity, along with the 48-hour rule actually being something that we follow and not get lost in the legislation again this year. And if I can just ask for the funding to be the highlight so we can actually get beds up and running and places for individuals to go versus the lack of space we have at all of the ones that we've closed since 2005 and beyond. Other than that, I guess I could go on for a long time with these issues, but I think I tried to keep it as concise as I could with some of those examples, and I'll be open to any questions anybody would have at this time.
We're going to add you. Thank you, Ms. Aldine. I guess Senator Rasmussen, there's a line of folks that are wanting to be in this conversation. I saw Mr. Freeman did submit a, yep, it's going to go, I think it'll go Abler, Utke, and then May-Quade, right? I think that's the line we got. Freeman's not walking over, so I assume that he's just good with the piece that is written there.
He's moving.
Funding. Do you remember 2 years ago, folks, when we talked about the $1.825 billion of underspending that occurred and how that went to the general fund? Now we're looking at $1.5 billion. Did I get that number right, Aaron May-Quade? $1.5 billion. Absolutely. I hear what you're saying, Ms. Aldine, and I appreciate that. So, Senator Rasmussen, to that point, you want to anything in addition, and then we're going to go to some conversations with the 3 members I just mentioned.
Thank you, Mr. Chair. Thank you for all the conversation. You know, 2 things that I'll also, and I wanted to briefly talk about Senator May-Quade's point on clinical decisions, because I think that's really important. This is an organization that is providing direct care to thousands and thousands of Minnesotans every day. And for me, that also comes down to the accountability piece. And we saw that with the EMS regulatory board, where this part-time sleepy board wasn't producing the results needed for emergency medical patients across the state, and we had to have that direct accountability, and that was something that had bipartisan support, whether it was Senator Lang or Senator Seeberger or myself, in making sure there was that accountability. And two places where you can kind of see that direct accountability from a patient care perspective. One is on the budget process. Again, this is an agency that perhaps in a couple of weeks will be asking for a biennial budget that starts with $1 billion, right? This is a big agency. And so to not have the governor be accountable for the results, but to think about including it into a budget package and giving it priority, I think is one key disconnect. It's different than a board of cosmetology that's self-funded through dues from licensees. And then additionally, one question that I don't know if it has been answered yet is today, everyone who is civilly committed in direct care and treatment is the ward of Jody Harpstead, is the ward of the commissioner of DHS. And Jody Harpstead, and as a commissioner, gets lawsuits probably on a daily, weekly basis on different issues that are happening because she's accountable. They are her wards as commissioner of DHS. And I would ask the question of, once we go to this executive board model, who are these thousands of individuals the ward of? This part-time board that meets 4 times per year, that maybe has good intentions and a nice resume, but is ultimately, those the people that we're going to be asking these individuals to be wards of when we think about accountability from a patient care perspective. And there's a reason that we just don't do this in state government. And when you look across the country, there's no other model where you see a part-time board running this an agency of this scale and magnitude. But thank you for the questions, and I'm happy to take more, Mr. Chair.
No, we're good. Senator McQuaid, you dialogue with him? Because by him asking him dialogue with you, you just bumped Senator Abler and Senator Utke, so, you should.
No, I appreciate that. And again, I have kept an open mind to this conversation. I guess what I'm hoping is that, I hear what you're saying. They'd be wards of the state of Minnesota, right? And that is who they would be wards of: the governor, the attorney general, if their civil rights are violated, the providers, the managers of the hospital. I think from Ms. Aldine's presentation, and it's so great when brilliant women come and give you like an overview. I guess what I'm seeing is that your bill is not addressing what the real problems are in this area. Like, I heard more beds, less Rule 20, ability to apply political pressure. We've got lower bail amounts, although I wouldn't want wealthy violent criminals on the streets either. So I don't know if bail is totally locked in, but 250 bed ask. I mean, are we asking somebody to be accountable to a system that we're not funding? And I guess I'm just hearing what Ms. Aldine shared. I had this like out of body experience. I was like, we're not even talking about the right thing here, of like a board versus a commissioner, because what I'm hearing is that we have more people who need this kind of care and not enough beds. So like, we could put a board to be accountable to that problem, or we could put a commissioner to be accountable to that problem, and then we can haul the commissioner in front of here and be like, when are you gonna follow the 48-hour rule? And the answer will be when you have more beds for us. And so I guess I was just having this moment of thinking like, yeah, this bill really maybe not be the thing, but what I'm more interested in is keeping the structure, but I am interested, Senator Rasmusson, in more than a part-time board. Because I do think that, the management of all of this should be overseen by more robust oversight. I just, everything that I'm hearing, it keeps coming back to me like, it's gonna be, what is the sexiest story? What's the, even the stories that we just heard, like, there are whole other pieces of those things that we didn't know about, right? And so I guess I'm just being left with all these questions about what do these patients, right? They're patients of the state of Minnesota. What does their care look like? What does the appropriate setting look like when a splashy news story can influence where somebody is for how long instead of their care needs, right? Where fear can be weaponized to influence somebody's civil rights and civil liberties instead of their needs and where their treatment is at. And so I am hearing you. I want you to know that. And I'm hearing the testifiers as well. but I don't know if going to a politicized structure is an answer to that. I feel like it's taking in to the parts you're concerned about and maybe beefing it up more.
That was the discussion last year that we were starting to have, was that which one makes sense. So I'm glad you brought those up. And thank you for reminding us once again, they are still people, citizens of the state of Minnesota that are receiving care and services. I mean, this is the last bastion of hope for a lot of people. This is our fail-safe. This is why we exist in government, right? And so let's make sure we get it right. And Senator Fatsa, it sounds like Senator Mayquade and Senator Jordan will be doing some conversation between now and next week, or when we do. Yes, we will. Senator Abler.
Well, thank you, Mr. Chair. I'd like to respond to the county attorney point by point. Oh, not really. Anyway, so I just appreciate your eloquent testimony.
You didn't even crack a smile out of Rasmusson. Do you get that? I mean, I got the humor up here. That was good. Even Glenn's smiling over there. That was good. Go ahead, Abler.
Ms. Aldi, and I really appreciate your testimony, and you undoubtedly know our County Attorney Brad Johnson, who we set up. I don't know, were you part of the work group that was together, but there had been very little discussion between the county attorneys, not county's attorney, and the department on this matter. And it was Senator Huffman, you and I got them connected, and somebody else. Was it the two of us?
Senator Abler, we were out on the front of the steps, and Brad Johnson from Anoka County, and it was the first time. I remember that night very well.
Yeah, but so there'd been very little discussion, and so at least good news, there's a discussion. And so we set about, because the department had wanted just to simply repeal it, and then they said, we'll let you know about this 48-hour rule. And I've been here long enough, I was untrusting of that agreement, and so there was this task force. Does it blink back on, the 48-hour rule? Did it stay, does it re-blink? Or does anybody know?
No, anybody?
And we blinked it off for 2 years, it just blinked it off forever.
Do we? No, it doesn't.
Whatever.
We'll
It's
find
gone.
out February 15th if it blinks on or blinks off, Senator Abler. I
Is
think
it, Mr. Green, does it blink back on?
Here
Anyway,
comes
but
Matt,
I just was untrusting about that, and she brought forward the idea that in the governor's budget, there's not a penny for this. In the past, there wasn't a penny either, and it's really a big deal. And to Senator McQuaid's idea, these are people needing care, and they're sitting in jails for interminable amounts of time when they belong in somewhere else, and so it just to me seems like a failure. If I could yield to Mr. Freeman, Mr. Chair, if I could ask
Senator
him.
Abler, I love that. I saw Mr. Freeman make his way up here. He was trying to get away with not testifying. Yield to you, Matt Freeman.
Matt Freeman, Executive Director for MAXA, the Minnesota Association of County Social Service Administrators, and Human Service Policy Analyst for the Association of Minnesota Counties. I believe that the sunset of that is coming up June 30th or July 1st of this year, which would adjust the language back to 48 hours strictly, rather than when a medically appropriate bed is available. And so that would change that timeline if the legislature does not take action this year on that.
Senator Abler.
Well, thank you, and stick around. So this is a really important topic, and the bill is about the structure of this group, and I think Mr. Storkamp is great. I think he's a diligent worker. He'd probably be the commissioner if there was one of this thing. But I don't think the work's getting done, and I think at least a more frequent meeting at the very least. And so, curiously enough, Senator Rasmusson, we do work in a political environment, and with these commissioners, which has been working as a method for a good long time. So there is one accountable figure in the state, whoever the governor is the final accountable party for all of this stuff. And so the budget comes, and it's the governor's budget, and frankly, he doesn't write most of these budgets, but he's the accountable party. And I don't know, these individuals need to be served, but we should just remember at DCT, it's not just people in some kind of a mental illness state with crimes that they've committed that they couldn't be tried for. There's all kinds of individuals who just need regular care, from people with various levels of disabilities in the MSOCS programs. And so I'm glad you're working on it. But I don't know that, I think Ms. Is it Eldon, I don't know that the governor is going to weigh in like he might have, or she might have, without this direct accountability. Well, I guess we'll see if it works. They didn't agree with our plan last year, and so here it is forward. And Ms. Eldon, that is the current structure. They meet irregularly, maybe up to at least 4 times, if not more. I think one thing that's going to happen, which I don't know is all bad, I never thought that our sex offender program was constitutional in the first place. The Supreme Court in Minnesota disagreed with me back with Emily Piper's era, if you remember that.
I do.
And so we have people locked up. It's a life sentence, and some of those people don't belong there. So if there's a highlight of this, by the way, Mr. Chair, there are no advocates for sex offenders.
Correct.
No one wants to run on that, but they do have human
Former
rights
state
as well.
rep. There's a former state rep that does on the constitutional, the civil rights piece of it.
Yeah.
You know.
And so maybe there'll be some more justice for those individuals because the political pressure goes away. That's the only thing I can think that's positive about this in terms of better justice will come. In the past, any bill that would make more crimes or longer periods of time for sex offenders passed with everybody voting for it except for maybe 1 or 2. Tina Liebling was brave enough to not always vote for those things. But, you know, I hope that the public will pay attention to this discussion, public being probably the accountable parties that are in office and in county associations and county chairs, county jobs that actually are affected by this every day. Because the people trust us to keep them safe, but they also think we're going to treat people reasonably, to Senator McQuaid's point. And I don't know, I'm glad you're tackling it. And I know that, but I mean, if there's any proof in the pudding, is that an archaic saying? Where in the governor's budget is a penny to address this bed issue? It's going to expire in June. And he bought plenty of other stuff while causing the ruination of nursing homes and disability services. But if it's important, then it should show up in the budget. So I talked long enough, so thank you, Mr. Chair.
No, you're welcome. No, thank you, Senator Ayler, for, I mean, there's historical, the thing you bring is that these questions have been circling around and around throughout the years on this, right? And I know for, perhaps in the DCT policy bill, I think that there might be a provision in there that removing the sunset, which then would assess for the medically appropriate bed being available. But if we're back at that point of no bed space, what are we truly doing what needs to be done, you know, to Senator Abler's question, right? So there's so many things. All you want to simply do is say, here's the accountability person, here's the accountability, this is what we want the process to be, and then the system does itself, right? But, you know, look what it's created. It created a wealth of conversation just about the care of individuals themselves. And so I'm grateful for that. Senator Utke, I think you're next, right? Or McQuaid, did we come in? No, go on to him. There you go. Senator Utke.
Thank you, Mr. Chair. And yeah, you kind of, as you just were talking, you brought it back into what we're looking at is this is just one bill of what could probably amount to be others, because we've heard about a variety of different needs, but the first thing we need to address is the accountability. And I like this, I thank Senator Rasmusson for bringing this forward, because this has to be a commissioner. I mean, this current setup, the current proposal, as I see it, is a total disaster. It's unacceptable. We need to bring it back in. It's a big state agency. All these people are, it's been mentioned many times, wards of the state of Minnesota. That accountability has got to be in play. And then we hear a lot about health care, and it is, but it's specialty care. St. Peter is a prison with mental health capacity. Anoka, psychiatric hospital, that does have hospital in its name. They are all secure campuses. These aren't your neighborhood hospital that you go to when we talk about health care for a surgery or getting a broken bone put back together and those type of things. So I think that terminologies messed up a little bit, but these are very unique. They have very unique patients and their needs, and they're operated totally different than the rest of our healthcare across the state. So we need to keep that in mind. And the fact that we're talking about having that top position as a commissioner and being accountable to the governor and elected officials around the table, I think is, I mean, that's at the top of this whole conversation. And again, hopefully, as this comes back before us, we'll be able to do something with this and move it through. So thank you, Mr. Chair.
No, thank you, Senator Udke. And that's, I think, if I remember right, last year, I think we voted on this, it was like 5-5 or 4-4. I think it was a split committee. This is the topic at hand, it was that conversation. So you got the good senator from Glencoe, Minnesota. He had raised his hand there, Senator Rasmusson. Senator Gruenhagen.
Oh, thank you. Yeah, I think this is a good discussion. Obviously, there seems to be quite a few problems. Here again, I wonder of what value it would be to know how other states, especially around us, deal with individuals that are similar to us, okay? Again, comparative data is one of the best ways to seek solutions, and there might be a state out there that has come up with some really good ideas that we're not aware of. I personally think I like the idea you're bringing forward, Senator Rasmussen, but you know, when we just look at ourselves versus, and again, there's got to be similar situations in our neighboring states of individuals like this. How are they doing it, and how do we differ? And are they more successful than us? And I don't know if Mr. Freeman knows anything about that or not.
I was looking, that's like, why does everybody say that? You know, the Minnesota, well, Minnesota, you know, we've done the best. Yes, because the Minnesota value is that. I love that, Glenn. Thank you for bringing that up. I don't know. Jim and I were just asking. I don't know what other states are doing. Do you know what other states are doing? I don't either. Dan Storkamp probably does, but he's sitting in there. Matt, do you know what other states are doing?
Mr. Chair and Senator, I don't know the specifics. I know that that was something that was reported on in the prior to admissions review panel in their work. We do have a larger number of individuals that are committed than in other states. There are other states that are also challenged by wait lists and priority
same issues.
Access. I think looking at that more comparatively from the data that will come out of the review panel may be a benefit to the committee.
Just, thank you, Senator Gruenhagen. Did that report, do you have a copy of that first initial task force report?
No, this is the first time I'm on the committee.
I love it, and that's why I love having you here. Can you get him maybe we can get a copy of that report to him, but thank you. Thank you for bringing that up. Senator Gruenhagen, follow up to that, or is that, nope? Senator Rasmussen. Yeah, we're good. I mean, it's been a good discussion. I don't know if anybody else wants to.
Thank you, Mr. Chair. I appreciate this, and I appreciate just getting this idea again out for the committee's consideration. And the hope and plan is that this bill will be before the committee at a later date. And so happy to consider further conversations, amendments at that time. And I just wanted to say, DCT has lots of issues and problems that need to be addressed. This bill is about ensuring that we have that core governance function there to build upon. And I think, you know, to partially answer Senator Gruenhagen's question on what do other states do, as far as I know, and DCT can correct me, no state in the country has a part-time board that runs a $1 billion+ agency with 5,000 employees. And when you look at the history of the state of Minnesota, this is something that Minnesota's been doing a long time. You know, there's a building in Fergus Falls where I represent that was built in the 1800s to care for wards of the state. And so this is a function that the state of Minnesota has had for a long time. We've always had a commissioner model, given the importance. And when you look to other states, you traditionally see a commissioner model as well. This would ensure that there's accountability. And I think whether you're a county attorney, a county social worker, a member of the public, a client, a patient in one of these programs, or an employee at any of these facilities, I think you're all going to be better served by accountability and not having a very part-time board that lacks that accountability. So I encourage continued conversation on this going forward, Mr. Chair.
Thank you. And you bring up the Fergus Falls, and I'll never forget Rick Cardenas, like 20 years ago, talked about the state institutions. When somebody would die, they would put them in a grave and they would not even put their name on it. You know, it's like, it just dawned on me. I remember that. It's just like, you know, we can do better in Minnesota, and that's what we're always striving to do, at least in this committee. Senator Abler.
You know, that's where we've come from. I think it's good to remember where we've come from with this very same population, where I hadn't thought to say that till he brought it up. And it was compelling when we got the bonding money, and it was controversial to some, to give people a name instead of a number.
Going into your high school that you graduated, the first class, there's that grave site to the left, and those were all unmarked graves.
Yeah.
Now they have actual names of people that are on it.
Yeah, I remember when we set up that, it was just momentous. But anyway, just to give context, but as you go forward, and Mr. Storkamp, thank you for your work. I hope that there can be some candid conversation, not that the author here will not give candid conversation, but behind the scenes. So I can't imagine that, given Senator, I'm speaking for you, Senator McQuaid, but that given her concerns about the welfare and the health of these individuals, that 4 times a year is sufficient. And I think if there's a consensus anywhere here that's an inadequate number. And so it'd be interesting to hear, and maybe it's at least 4, and so maybe it's all gonna be fine, you'll meet more often, but it's gonna set up itself on July 1 way or the other. And I think we've heard from the county attorney that there's just already big gaps there. And so I'll just, can I play make-believe? So people that work for the governor, they have to say, well, the governor says this. And like by leave of whoever the governor of the moment is, in that department head or whoever, they're not allowed to think actively and create the best possible scenario. I think we all agree that these individuals need the best possible care in the best possible place at the right time, and be moved along if they're allowed to be out, and held in if they're not quite ready. And I think the way to have that happen is with the phenomenal people who are the state employees and these directors or whatever we're calling the not commissioner job, are able to actually use their intellect and, at least behind the scenes, work with their hierarchies and make this the best it can be. So I just want to thank you for the time, and Senator Rasmusson and all the testifiers for what's going on. And it just needs to work, Mr.
Yeah, it does. I love this group. This is what we talk about. Senator Gruenhagen.
Yeah, real quick. I got a question for the county attorney, Otter Tail County Attorney.
Ms. Aldine, are you still on?
I am.
Yes.
Yeah, and thanks for your testimony. And are you aware, I don't know if you are not, what states like South and North Dakota do in similar situations? Do you work with any of those individuals from time to time? Is there any major differences between how we approach things here in Minnesota versus other states?
That's a great question. Ms. Aldine.
Yeah, Senator and other members, I don't have specifics, but I do know, just from my position and probation and different issues we've had over the years with who's committed here, who's sentenced and things like that, that most of the other states, including those two, have a lot more individuals in prisons and have sentences that are a lot different than ours. So we have a tendency in Minnesota, of course, to have many more individuals that are kind of in this gap type area. And number-wise, I know we just have a lot more defendants in those situations. But what they actually do, I do not. I know when we studied the Rule 20 changes to the statute not too long ago, we were looking at other states and modeling, and I know some of the model came after the federal government as well. But that's all I know.
Thank you, Senator Gruenhagen. Thank you very much for that question. This strikes me. I start thinking about how the individual was treated up in Cambridge, 352 times 5-point restraint. People might know it as the Jensen Settlement Agreement, right? And one of his sins was he wanted a glass of milk at 8:05 p.m. and his program ended at 8 o'clock. And it's just like when I heard Aldine Ms. Aldine say, you know, there's a lot more of them in prison. That just strikes my nerve as it's wrong. Minnesota, we're attempting to do the right thing on behalf of people that really truly need the support and services. So I'm grateful for this conversation. I don't see anybody else having these types of conversations, and it sounds like we got some work to do. I heard Senator Fata and Senator McQuaid. It's like we're all embedded in doing what's focused with the matter at hand. I appreciate you coming here. Speaking of which, then, if you are having the conversations, the thing that really sets me, Senator Abler just announced he's the co-vice chair. He just pointed that out his folder, isn't it? The makeup of the board, and I know that's not germane to your particular approach, but that's also something that I looked at and I said, you got to be kidding me. There's no advocacy, there's no protection in advocacy, there's no, I mean, it's just what you would think would be that. It looked to me like this hospital board. And if that's what you want to do, that's what's going to get us in trouble, right? And so if we're truly going to be responsive to the unique and individualized needs of that person and their disability and or their need that's unique, then we got to have the right people being responsive. So I'm thankful for you for bringing that question back to us, and that we're having this conversation. And this committee, of course, you know, at the end of the day, we'll see what the committee decides we want to do with that. So, and with that, Senator Rasmusson, Wednesday, there'll be, if you're ready, if the folks here on the committee have got you, and you're ready to do the official motion on Senate File 626, then we'll do what we need to do with that. I know it's going to be the Natasha and Josh show on the acute care transitions report that's due to us. That'll be good, with good conversation on that. PACE, Natasha is going to do an update. Ms. Mirza is going to do an update on PACE. EIDBI, Christy Grom is going to present us with her knowledge, and then Christy's also going to think a little bit. We might have a little conversation about some obsolete rules. Is that correct? But that's, so in addition to, that's what I have. At least that's what Bryce and David have told me what we're doing on Wednesday. If there's anything else that needs to be done, we can do that. But Senator Rasmusson, with that, you get to pick who gets to chair us next week, because it's your bill. So, you know, maybe start it off and we go from there. But members, any comments, questions? Thank you, everybody, for being here. We are adjourned.
Thanks. Appreciate it.